Hello and welcome to Insight Ophthalmology. I'm Dr. Amrit and I welcome you to another lecture in our Keratoconus series. Today we are going to be talking about the management of keratoconus. In this video, we will cover some important classifications that we missed in our previous ones. We'll also discuss how to understand the progression of keratoconus, when to intervene, and how to intervene. We'll go over an algorithmic approach to keratoconus management and we'll touch upon each treatment just enough to understand the logic behind when and where it's used, but without diving too deep into the advanced stuff. That will be covered in a separate video. The video is mainly for beginners to moderate level viewers to help you get a clear picture of what treatment is used, where, and why. So let's get started. So, the first classification, we are starting off with the morphological classification of Buxton. This one is based upon the shape of the cone. We have the nipple cone, which is less than or equal to 5 millimeters in size and is usually found centrally or paracentrally. Then there's an oval cone involving one or two quadrants, and this oval cone usually involves the inferior part of the cornea. Finally, there is the globus cone, which involves more than 75% of the cornea. As we progress from the nipple to globus, the severity increases and accordingly so does the complexity of treatment. So, while a nipple cone might be managed with a smaller diameter or even a soft contact lens, once you're dealing with an oval or a globus cone, the management becomes more surgical or may even require advanced modalities. So, don't worry, we'll talk about all of these in a while. Another classification is based on the central K values, where mild keratoconus is less than 45 diopters, moderate is 46 to 52 diopters, advanced is 53 to 59 diopters, and severe is more than 59 diopters. So, mild cases might be managed with simpler contact lenses, while moderate to severe ones usually need advanced options. Then we have the Bellin ABCD classification. Here, ABCD is an acronym. A stands for anterior radius of curvature in the 3 millimeter zone, B is the posterior radius of curvature, C is the corneal thickness at the thinnest point, D is the corrected distance visual acuity. All these four factors are considered in this classification. So, this system helps us assess the disease holistically and also track progression more accurately. So, we'll talk about progression in a while. So, how do we define progression? That means, how do you tell whether your patient has progressive keratoconus or a stable keratoconus? Here are four main signs. That is, if there's an increase in the astigmatism of about 1 diopters or more, significant change in the refractive axis orientation, or if there's increase in the optical power of the steepest meridian more than or equal to 1 diopter, and decrease in the corneal thickness by 25 microns or more. If any of these 4 points occur within a year, that is known as progressive keratoconus. Alternatively, the Global Delphi panel gives us three criteria, that is, progressive steepening of the anterior surface, progressive steepening of the posterior surface, and progressive thinning or increased thinning rate. If two or more of these are present, then the disease is said to be progressive. So, for the beginners, I would advise you remember the Global Delphi panel. Now, we can also use the Bellin ABCD progression display. This is an automated thing which is a part of the advanced tomographers like the Pentacam. So, this tool will track all the changes that we discuss under the ABCD parameter of the Bellin classification over time, and this offers high sensitivity for early progression, especially in borderline cases or the cases which have been treated before. All right, now let's look at the factors that influence management decisions in keratoconus. These can be divided into the host factors, clinical factors, the surgeon, and the facility factors. Let's go one by one. First of all, are the host factors. So, age play a big role. Patients who are under 25 years of age, they are more prone to progression. So, they are prioritized for cross-linking. We'll discuss about that in detail shortly. Older patients usually have a stable disease, So they may just observe or go for visual rehabilitation. Atopy or eye rubbing is something which can accelerate progression. So, anti allergic medications, behavioral modifications like advising patients to avoid eye rubbing is something which is essential. Similarly, some patients might have another issue, and that is contact lens intolerance. Since many keratoconus treatments involve these contact lenses are used both in stable as well as even in post cross linking patients. Intolerance to contact lens is going to push them towards specialty lenses or even surgical options like the penetrating keratoplasty. Lastly, we also need to consider the visual needs, the lifestyles, that is, say, if your patient is a driver, student, or a digital worker, your treatment plan should match their expectation. This might influence your choice of whether you're using a spectacle, RGP lens, scleral lens, or surgical intervention. Then we have some clinical factors which will change our management decisions. Number one is the severity of the disease. We know how we classify keratoconus based on the central keratometry values. So, mild cases with less than 45 diopters might be managed conservatively with spectacles or even with soft contact lenses. Moderate to severe ones will need advanced lenses from RGP to scleral lenses and even PROS lenses and even some other specialty lenses. Also, some of these might land up with surgery as well. Don't worry, we'll talk about all of these. Next is the cone location. This is also important. Central nipple cones, they are good candidates for cross linking and even for soft lenses, RGPs, whereas inferior cones, decentered cones may benefit more from surgical options and advanced group of lenses. Third clinical factor is corneal thickness. This is also critical. The typical cutoff for cross linking, which is a treatment to halt progression of the keratoconus, is 400 microns. And when I say 400 microns, I'm talking about the standard Dresden protocol of cross linking. Don't worry again, we'll talk about that. If the cutoff, if the corneal thickness is less than 400, then you might have to go for epithelial on technique or customized protocols. So, what is this epithelium off and epithelium on? Stay tuned. Then, the fourth clinical factor is scarring or presence of high drops. Now, this also changes the approach. Scarring may make patient unsuitable for refractive correction. So, these patients you will have to consider deep anterior lamellar keratoplasty or penetrating keratoplasty. Moreover, if the patient has had high drops, you need to wait for it to resolve before any surgery is attempted. Also, if there's high drops, the patient would basically need a penetrating keratoplasty. The third set of factors are the surgeon factors or the facility factors. This includes your experience and available technology. Procedures like DALK or ICRS are surgeon dependent and they have a learning curve as well. ICRS is basically placing a ring segment inside the eye via a laser tunnel. So you use your laser, and using the laser, you make a tunnel in the mid periphery of the cornea, and then you implant an arc shaped plastic implant within the cornea. Okay, and this somehow flattens the steep cornea. I'll talk about that. So, for all of this, you need advanced technology, especially if you're even doing topographic guided PRK, which is photorefractive keratectomy, femtosecond lasers, custom cross linking protocols. So, tech access is important. Even when you talk about surgeons, there's variability. Some may prefer cross linking first, others will go with specialty lenses. So, your practice setting matters too. Academic, whether it is a private practice or it's a rural practice, for instance. In rural settings where follow up may be difficult, even the borderline progressors might be treated more aggressively. Let's now move on to the stepwise approach to managing the keratoconus. Step number one is how do you universally manage all the patients of keratoconus? Regardless of progression, you need to start with patient counseling. Here, we explain the disease course that typically keratoconus is a progressive disease and then it slows down after 40 to 45 years of age as the cornea stiffens naturally. Pediatric patients progress faster, so pediatric patients and their parents need to be more cautious. Also, advise patient to avoid eye rubbing, and also you have to treat atopy, any vernal keratoconjunctivitis and dry eye first. Along with that, we should get baseline measurements including the best corrected visual acuity with spectacles and best corrected visual acuity with contact lenses if possible at your setup. This is important because it tells you about the visual potential of the patient. Step number two is determining progression. After you know that your patient has keratoconus, it becomes really important also to know that whether the disease is progressing or not. We already covered how to define progression using the Delphi and the Bellin criteria. All right. So now we know that our patient is either progressive or non-progressive keratoconus. First, let's discuss about the non-progressive cases. Here, we divide the patients into a high-risk category and a low-risk category. What is meant by the high-risk category? High-risk patients are those patients of age less than 15, or they might have severe vernal keratoconjunctivitis, or they might have had high drops in the fellow eye, or patients with a doubtful follow up. All these cases become high risk because although they are non progressive in nature, there are high chances that they might progress or you might miss them as they are progressing. So, in these high risk cases, even if they are non progressive, you go ahead and do the cross linking. The other category are the low risk patient. So low risk includes the older age, no other risk factors. So in these patients, the question that you ask is that is vision acceptable in these patients with spectacles or lenses? So if the patient gets good vision with spectacles or lenses, you will prescribe them. However, there might be some patients who might be contact lens intolerant or they might have problem with spectacles. In these patients, you will go ahead with the advanced options for visual rehabilitation. This might include specialty lenses like the scleral, hybrid, piggyback, or pros lens, or it might also include intracorneal ring segments or the surgical options like the keratoplasty. Now, let us briefly talk about the contact lens options which are available for keratoconus. So, we have variety of them. We have soft lenses, the rigid gas permeable lenses, hybrid lenses, piggyback lenses, corneoscleral lens, scleral lens, and even the custom soft lenses like Kerasoft and highly customized scleral lenses like the Pros lens. So, the soft lenses are used only for mild cases because they are not well equipped with correction of astigmatism. Although toric soft lenses are available in the market, they are also useful only in the earliest cases of keratoconus and very mild cases. The rigid gas permeable lenses form the mainstay of treatment for keratoconus. They basically vault over the cornea. That means there is a space between the lens and the cornea, unlike that of the soft lenses. So, this space gets filled up with the tears, and these tears will smoothen out the effect of irregular cornea. And therefore, RGP are the main treatment for visual rehabilitation in keratoconus. However, not all patients can tolerate the rigid lens, and therefore we have other sort of lenses like the hybrid lenses and the piggyback lens. A hybrid lens basically means you have a rigid contact lens in the center, and that is surrounded by a soft skirt that sits on the cornea for better comfort. In a piggyback lens, the patient wears a soft lens which provides comfort, and on top of that, the RGP is placed. So that means at one time the patient is wearing two lenses, and this is known as piggyback lens. Apart from that, we have larger diameter lenses used for advanced cases of keratoconus, and these are the corneoscleral and the scleral lenses. In very advanced cases, we can use custom soft lenses like the Kerasoft and even pros lenses, which are highly customized, individualized scleral lenses, specially made in the Boston centers. Don't worry, we'll talk about all of these in a separate video on contact lenses for keratoconus. Now, as you can see in this table, for less than 45 diopters, spectacles and even soft lenses and soft toric lenses can be used. 45 to 52 diopters, you have to use rigid gas permeable hybrid or scleral lenses. And above 52 diopters, scleral lenses, customized scleral, and even other ways of visual rehabilitation might have to be used, like ICRS and keratoplasty. So that was the treatment of non-progressive cases of keratoconus. What do we do once we know that our patients have progressive keratoconus? So the only proven way to halt progression is collagen cross-linking. So what is collagen cross-linking? So in a simplified way, we basically apply riboflavin drops to the cornea for 30 minutes. This is done after debridement of the epithelium in the classic protocol of Dresden. And after that, we shine UVA light of 370 nanometers for another 30 minutes. Riboflavin gets activated and this produces reactive oxygen species. These will now create new bonds between the collagen fibers, and the result is a stiffer cornea, preventing further thinning and bulging. In the first picture, you can see there are fewer bonds which are marked in green color, and after cross-linking, there are greater number of bonds between the adjacent collagen lamellae, making the cornea stronger. Alright, so now there are some important beginner terms to understand. We are not going into the depths of collagen cross-linking, that's a separate video in itself. However, a beginner needs to know certain terms. So the classic protocol is the Dresden protocol, and in this the epithelium is removed, and therefore this is known as the epithelium-off procedure. Okay, the surface layer of the cornea is the epithelium that is removed so that the riboflavin can get soaked in better. Then we have an epithelium on, and here the epithelium is kept intact, and this causes less discomfort, and maybe it's also less effective in some cases. Now, since you are not removing the epithelium and you're applying the UVA light through the epithelium, this is known as the transepithelial cross-linking. Then we have an accelerated cross-linking. This is going to use a stronger UV but for a shorter period of time. Okay, this is quicker and still effective in many cases. So now this, how do you choose the procedure? This is basically based on the corneal pachymetry. Now this brings us to the prerequisites of collagen cross-linking. Now the minimum corneal thickness for the standard protocol of Dresden for collagen cross-linking is that the minimum corneal thickness should be at least 400 micrometers or more than 400 micrometers. Also, there should be absence of scarring or active infection, and if any ocular surface disease exists, you have to manage that first. That means any dry eye, weak AC or allergy, that needs to be treated initially. Alright, so once we have identified that our patient has progressive keratoconus, the next question we ask is collagen cross-linking feasible in this patient? Now, cross-linking may not be feasible in certain situations, and you should be aware of these. Cases where cross-linking is not feasible include severe corneal thinning, central corneal scarring, and acute eye drops or a history of eye drops. So what do we do in such cases? Even if we can't halt the progression, we can still aim for some degree of visual rehabilitation. So how do you do visual rehabilitation in non-cross-linking candidates? So if the vision is satisfactory with the contact lenses, remember I told you that in all the patients we have to do a contact lens trial and assess the visual potential of the patient. So while assessing if the vision is satisfactory with contact lenses, then one option you can consider is the Bowman's layer transplantation, and this can be followed by the continued use of contact lens. Now, what exactly is this Bowman's layer transplantation? Let me break it down for you. In keratoconus, it is postulated that there is fragmentation of the Bowman's membrane, and this may contribute to progressive ectasia. So the idea here is that if we can replace that fragmented Bowman's layer, we might be able to provide some mechanical support to the cornea and help stabilize its shape. That's why BLT, that is the Bowman's layer transplantation, has recently gained interest, particularly in eyes with low pachymetry steep keratometry, and in cases that are not ideal for cross-linking or other interventions. Now, but what if the contact lens vision is poor? Now, let's say that the patient is not achieving good vision even with contact lenses. Now, in that case, rather than going for the Bowman's lead transplantation, you will need to step up to either a deep anterior lamellar keratoplasty or a penetrating keratoplasty. The decision between the two depends on the level of stromal involvement and whether the endothelium and descemet is healthy or not. In deep anterior lamellar keratoplasty, basically only a part of the stroma is removed and the endothelium is left behind. Whereas in penetrating keratoplasty, you would basically replace the entire cornea with a donor cornea. Now, what if the cross-linking is feasible? Now let's look at the other side. If the cross-linking is feasible, then great. You move forward, but you need to evaluate the pachymetry. Here's how you stratify. If pachymetry is more than 400 microns, you proceed with the standard epithelium-off cross-linking using the Dresden protocol. If the pachymetry is less than 400 microns, you can't use the standard protocol. Instead, you have to use hypoosmolar riboflavin protocols and the accelerated cross-linking, or even the transepithelium or the epithelium-on techniques depending on the patient profile. Post cross-linking, this patient would also need visual rehabilitation. So cross-linking, remember, basically halts the progression of the disease, but the patient might still not be happy. For that, you need to visually rehabilitate the patient. So now after cross-linking, whether it is standard or modified, your next job is to assess vision and contact lens status. If the vision is good, you can just prescribe glasses and fit them with the contact lenses, but sometimes patients might have poor vision or might be contact lens intolerant. In those cases, you look at the other options for visual rehabilitation. What determines the next step is again pachymetry. Now, if the pachymetry is more than 450 microns, you can go ahead and even do a topographic guided PRK, that is photorefracted keratectomy, with simultaneous cross-linking. So this is basically a standard PRK but guided by a corneal topography to correct the irregular astigmatism. Now, if the pachymetry, however, is between 400 to 450 microns, then PRK is off the table. Instead, you look at the intracorneal ring segments. I think this would be the correct time to talk a little bit about intracorneal ring segments. Now, ICRS basically stands for intrastromal corneal ring segments. These are arc-like plastic implants that are inserted into the mid-peripheral corneal stroma. So how do they help? They apply a mechanical flattening effect on the steep cornea, helping to regularize the surface and improve the vision. So basically, you create a tunnel in the mid-peripheral area of the stroma. Either you do it manually or you use a femtosecond laser. And then you insert one or two of these rigid segments into those tunnels. No sutures are needed. The segments will stay in place on their own. Now, these segments will act as spacer elements and they basically exert some sort of outward force, increase the volume of the cornea. And as they do so, they have this arc shortening effect and they also decrease the steepness of the cornea. Right? Now, these implants come in various sizes and thickness, and the choice depends upon the cone location and the severity. Now, it has been seen that they are more effective if the segments are thicker, placed more centrally, or they have a longer arc length. Okay, so you can decide accordingly. Now, back to our cross-linking limited group, if pachymetry is less than 400, we have done hypoosmolar and accelerated cross-linking. After this, again, you need to visually rehabilitate the patient. You can use either advanced contact lenses or you can use surgical modalities like DALK or penetrating keratoplasty. Alright, to summarize, every patient of keratoconus deserves a universal initial approach, proper counseling, education, thorough ocular surface treatment, and baseline visual acuity potential testing with both spectacles and contact lenses if possible. From there, we divide the algorithm into two major pathways based on the progression. Non-progressive keratoconus, here visual rehabilitation becomes the mainstay of treatment, using options like glasses, soft toric lenses, rigid lenses, hybrids, scleral lenses. It all depends upon the level of irregularity, vision, and quality. Also, you might have to resort to penetrating keratoplasty and DALK as well. Progressive keratoconus, the key question here is cross linking feasible? This depends primarily on the pachymetry. If cross linking is feasible, choose the appropriate technique epi-on, epi-off, or accelerated based upon the corneal thickness and surgeon's preference. If the cross linking is not feasible, you explore other interventions like Bowman's layer transplantation in patients who still achieve good vision with contact lenses, or go for deep anterior lamellar keratoplasty or penetrating keratoplasty when visual rehabilitation fails. Also, note that even non progressive keratoconus patients at high risk for progression may need prophylactic cross linking, and regardless of cross linking status, visual rehabilitation is always necessary to achieve optimal vision. So, we have tried to cover the essentials from basic terminology like epi-on, epi-off, accelerated cross linking, and contact lens option to building a logical stepwise management plan that serves both beginners and moderate level learners. So stay tuned for advanced level videos on the keratoconus management, which will be coming up soon in the membership section. All those who are interested in joining the membership, they can join it using the link provided at the end of the description box. That's all for today. Thank you so much for watching, and take care and have a nice day.